So let's first go to the questions. We've got an 86-year-old woman with a history of hypertension, no previous coronary history, had TPA administered for an inferior STEMI. She's pain-free on arrival, hemodynamically stable, resolution of ST elevation, then she develops chest pain and new onset dyspnea. On exam, she's in moderate distress, she's laying supine. She's in moderate distress, she's laying supine. She's in moderate distress, she's laying supine, okay? With a new systolic thrill present, large V wave on the wedge pressure from the Swan-Ganz catheter, which of the following is most likely etiology of her presentation? Free wall rupture, VSD, right ventricular infarction, papillary muscle rupture, complete heart block. Punch in your answer. She's laying supine. She's laying supine. So remember the fact that this woman was laying supine when Jeff gives his lecture. Okay, we've got a 72-year-old man who presents with 2 hours of crushing chest pain and diaphoresis. He's got ST elevations in the inferior leads, taken to the cath lab where the proximal RCA is the culprit lesion intervention. He's had a successful revascularization with successful flow post-intervention. Next slide. He's taken to the CCU for further care. His vitals, though, are a heart rate of 120, blood pressure 80, respiratory rate 18. His venous pressure is elevated with X and Y descents. In addition to S1 and S2, and S3 is audible and the lungs are clear. Next step in the management includes fluids, furosemide, emergency echo with a needle, cardiac surgery consultation, IV dobutamine. Next step in management on this guy with an inferior STEMI, underwent revascularization, now pretty sick. Okay. Number 3, 75-year-old man, acute dyspnea 8 hours after revascularization for an acute infarct. You're concerned about an acute papillary muscle rupture. If you're thinking about a papillary muscle rupture, you have to know what's going on. So either an anterolateral papillary muscle is the most common etiology, early beta blockade improves mortality, a harsh pansystolic murmur is typically present, medical stabilization for 48 hours has worse prognosis than urgent surgery, cardiac MRI is the preferred diagnostic test. So which is correct if this guy really does have a papillary muscle rupture? Okay. All right, Dr. Geske, come tell us everything we need to know about mechanical and acute complications.
Well, thank you very much, Dr. Nishimura. It's a pleasure to be speaking here to y'all. My title of the talk today is Complications of Myocardial Infarction, and hopefully we'll finish and get everyone to what sounds like a delicious dinner tonight. I have no disclosures for this talk, and my learning objectives are really threefold. One, to recognize and diagnose mechanical complications of myocardial infarction. 2, to select appropriate management for those patients. And then 3, to review post-infarct complications and the treatment strategies that go along with them. In order to understand complications of myocardial infarction, it's really great to have a framework because there are so many different things that can go wrong after an MI. And the way that I generate that framework is I kind of bucket things into one of 3 categories. They're either mechanical, electrical, or something else. And that something else can include either pericardial or thromboembolic and bleeding. Of these, the greatest or largest category ends up being that of mechanical complications, and we can split those either into the unruptured or the ruptured complications. Looking at the unruptured complications, this encompasses profound left ventricular failure, RV infarct, LV true aneurysm, ischemic mitral regurgitation, as well as dynamic outflow tract obstruction. Rupture complications, on the other hand, can involve the free wall, the papillary muscle, or the ventricular septum. We're going to start by looking at the unruptured complications first, but we'll go through each of these in turn. First, we'll take a look at profound left ventricular failure. And in order to do that, it's great to have a definition that we can agree upon for cardiogenic shock. So cardiogenic shock refers to a decreased cardiac output in the setting of adequate intravascular volume with signs of reduced end organ perfusion. Hemodynamics, this is a systolic blood pressure 80 to 90 millimeters of mercury that's sustained low for 30 minutes, accompanied by an elevated wedge pressure and a reduced cardiac index. The number one cause, particularly as we're talking about acute myocardial infarctions, is an extensive infarct. And you should be thinking about an extensive infarct when 40% of the myocardium is involved. So typically that's going to be an anterior infarct. But extensive infarct is not the only cause post-MI of cardiogenic shock. There's things like RV infarct, rupture syndromes, and the arrhythmias, all of which we're going to discuss during this talk. And there are other non-post-MI causes of cardiogenic shock, PE, aortic dissection, tamponade, which are covered in various other aspects of this course. With regards to profound LV failure, the risk factors include elderly patients who are diabetic. Typically, this is an anterior infarct, and they may have had prior infarcts that have reduced their strong contractile myocardium. This occurs in more severe coronary disease and in the setting of early use of beta blockers. And the first time I heard that, I said, what? Didn't we just have all those lectures that said beta blockers were really good in the setting of myocardial infarction? Well, how's that end up working? And that brings us to our first key trial. And maybe I should add a disclosure that I have a really bad sense of humor. So this is our first key trial, the COMMIT trial. And for each of the key trials, we're not going to give you a whole bunch of figures. We're just going to say, what was the question that was asked, what were the trial basics, and what's the take-home point for the trial. So the COMMIT trial said, if we take a very large population of patients with acute myocardial infarction and then give them high-dose protocolized beta blockers immediately following the infarct, do they do better? So if you look at what actually happened, immediately following the infarct, the people that received metoprolol received very high doses. So 5 milligrams IV every 2 to 3 minutes until you got to 15 milligrams, and then 50 milligrams orally every 6 hours. And they gave this so long as the systolic blood pressure was greater than 90 and the heart rate was greater than 50. So if you had a systolic blood pressure of 91 and a heart rate of 54, here's another 5 milligrams of IV metoprolol and 50 milligrams of oral 2 minutes later. Right? So you can imagine that this could run into some problems. And while they were able to reduce reinfarction and VFib, there was an increased risk of cardiogenic shock. So the take-home point from the trial is that you want to avoid these very high-dose protocolized IV beta blockers in acute myocardial infarction. It does not say that you can't give a beta blocker in the setting of an acute infarct, but you have to be careful and put on your thinking cap when you do so. When we look at profound LV failure, this is a bad actor. Although it accompanies only 10% of infarcts, it carries a substantial mortality, 70 to 80% mortality. And so we want to learn about treatments that can help to optimize this. And that brings up the question, should we be pursuing emergent revascularization with PCI or CABG in these patients? And that's the question that was asked in the SHOCK trial. So the SHOCK trial took and randomized 302 patients who had an acute STEMI with cardiogenic shock, either to medical therapy, which could include thrombolysis, fibrinolysis, or emergency revascularization. It was about 50-50 whether a patient went to CABG or to PCI. And they said, what's the result of that? Is emergency revascularization with PCI or CABG needed in these patients? And a little bit surprisingly, when they looked at all patients at 30 days, there was not a benefit seen in the entire cohort. But if they looked at patients who were less than 75 years old, those patients did benefit They had reduced mortality at 30 days and 1 year. And when they did longer follow-up and looked at 6 months, 1 year, and 6 years at the whole cohort, they found out that those who underwent revascularization promptly with PCI or CABG did better. So this really translates to the guideline recommendations that if you present with cardiogenic shock, that in the first 36 hours, if you're young, less than 75 years old, that you should undergo prompt revascularization. And not only that, it's probably okay for everyone, because when they looked at that longer-term data, even those over age 75 did just fine. So the take-home message from the shock trial, early PCI or CABG for shock, particularly for those patients less than 75 years of age. And what about balloon pumps? Should we be putting balloon pumps in all these people? We know that their hemodynamics are unstable. What's the level of evidence for that? That's the SHOCK 2 trial. So SHOCK 2 said, let's take a group of patients who are presenting with non-rupture cardiogenic shock and see how balloon pumps perform. And it was kind of underwhelming. There was not a mortality benefit seen at 30 days or at 1 year in those patients that received an intra-aortic balloon pump. Now the guidelines, they give us a little bit of wiggle room, but the take-home message here is really this is not the first-line therapy in cardiogenic shock. Balloon pump is not the first-line therapy. The guidelines tell us that we can still do it, and in fact the US guidelines still have a class 2A recommendation, and they say that patients may actually need alternative forms of mechanical support if they're refractory hemodynamics. But the European guidelines differ a little bit, and that kind of makes sense. When you look at the results of the SHOCK 2 trial, it says, you know, there's not really overwhelming data that tells us we should be doing this, and so while we have a 2A recommendation, Europe says, well, maybe 2B. And so when you have patients presenting with hemodynamics that are unstable, make sure that you're optimizing their volume status, that you're reaching for the right drugs, and then if necessary, you can turn to the intra-aortic balloon pump or alternative mechanical support. Is there any role for anti-inflammatory drugs? We know that much of the process that's going on in acute MI is inflammation-driven, and some early animal studies were promising looking at nitric oxide synthase inhibitors or complement inhibitors. So they started doing some trials looking at that, Triumph and Apex AMI, and they stopped them both early because there was no signal for benefit. And so if those are on the boards, don't pick those. Okay, those are not the right answers, those are not used. So we've talked about profound LV failure. Let's move on to our next unruptured complication, that of RV infarct. RV infarct doesn't happen with most infarcts, only 10%, but is much more likely if you have a right infarct, a proximal right coronary occlusion, and it goes along with about 1/3 of all inferior STEMIs. These patients have higher in-hospital mortality, but if they survive their initial hospitalization, they actually do okay. The RV is oftentimes able to recover. Diagnosed by a 1 millimeter elevation in either leads V1 or V4R, shown in both leads here. And here we have an accompanying transthoracic echocardiogram shown in the apical 4-chamber view, and we can see that the right ventricle is dilated and diffusely hypokinetic in this patient experiencing an acute RV infarct. The pathophysiology and hemodynamics of this are fascinating. So acute ischemia results in systolic dysfunction. So the RV systolic pressure and the RV stroke volume go down. Because the RV stroke volume goes down, the left heart becomes underfilled. There's reduced left ventricular preload. And normally when we see patients who have an elevated JVP, we think that probably there's high LV preload, but this is a case where it is discordant. The LV is underfilled, resulting in a reduction in cardiac output. The RV acutely dilates to try and accommodate this, but because of the acute nature, this is oftentimes insufficient. It's not just systolic dysfunction either. There's accompanying right ventricular diastolic dysfunction, and you can get a right-sided S3. A right-sided S3 is something that should cue you in to the presence of an RV infarct. As the RV dilates, there's only so much space in the pericardium, and it can become squishing the LV, further impairing left-sided filling. There's a classic triad that you should recognize. Patients with RV infarct present with hypotension, clear lung fields, and elevated JVP. Now, this may be a familiar scenario from some of the pretest questions, and sometimes this can be confused with tamponade. But use your exam to help you out. That right-sided S3 goes along with RV infarct, and you can also look at the neck veins. In a right-sided infarct, an RV infarct, you'll have a preserved Y descent, whereas in tamponade, you lose that. So in other words, you lose your Y before you die, okay? Lose your Y before you die, loss of the Y descent makes you think tamponade. The right atrium plays an important role in RV infarct. RV is not isolated. Because the RV becomes so preload dependent, loss of AV synchrony, be it complete heart block or atrial fibrillation, means that you lose that atrial prime, that additional filling that atrial contraction provides, and this further worsens right ventricular preload. As the RV becomes more and more hypokinetic, right-sided filling pressures go up, and the right atrial pressure can exceed that of left atrial pressure, and you can get a right-to-left shunt across a patent foramen valve. Because you have a right-to-left shunt, this results in hypoxia. And hypoxia itself can make things worse, because hypoxia can trigger pulmonary vasoconstriction, and pulmonary vasoconstriction increases RV afterload, which makes it harder for the right heart to work, which increases right-sided filling pressures, which means you shunt more. It's a vicious cycle. Treatment is prompt reperfusion, and as many members in the audience recognized, increasing the RV preload despite the elevation in the neck veins is key. IV fluids are a key therapy for RV infarct. Some patients may require inotropic support, and selection of which inotrope very much depends on the hemodynamics. Maintain AV synchrony because you need that right atrial kick. And you want to avoid hypoxia or PEEP, positive end expiratory pressure ventilation, because these increase your RV afterload. Let's now move on to LV aneurysm. This is sometimes referred to as a true aneurysm. This most typically occurs in the setting of a STEMI, where you've had acute vessel occlusion resulting in transmural ischemia. You've affected all layers of the myocardium, transmural ischemia, to develop a true aneurysm. It's most frequently seen with anterior infarcts and involves the apex, and incidence has gone down as we've pursued more timely reperfusion. Here we see one not involving the apex, but we know this is a true aneurysm because it involves all layers of the myocardium, and it has a broad-based neck. Okay, a broad-based neck involving all layers is a true aneurysm. These have very low rupture risk because they involve all layers of the myocardium. Here we see an MRI provided by Dr. Anna Vakar. Thank you so much, Nandan. And we see a true aneurysm involving all layers of the myocardium here with a broad-based neck. What about ischemic mitral regurgitation as an unruptured complication? This is not a problem with the mitral valve leaflet so much as it is with the ventricles. As the LV remodels and distends in the setting of ischemia, there's displacement of the papillary muscles, which results in tethering of the subvalvular apparatus, and the mitral valve leaflets have difficulty closing. Sometimes a picture is worth 1,000 words, and here we see an example of this. This patient has had a posterior lateral infarct. We can see regional wall motion abnormalities in this distribution. It's resulted in decreased motion of our posterior mitral leaflet and anterior mitral leaflet override. When we place color on this, we can see an eccentric mitral regurgitant jet in the setting of this LV dysfunction. The problem is the ventricle. Treatment focuses on treating the ventricle because the problem is the ventricle. So timely reperfusion and then optimizing hemodynamics, diuretics to reduce congestion, and then we want to decrease the afterload because this promotes antegrade blood flow out the left ventricular outflow tract. It's easier to pump blood forward out the outflow tract, and so not as much regurgitates backwards. The more residual mitral regurgitation you have after an infarct, the worse the long-term survival. The last unruptured complication is that of dynamic outflow tract obstruction. And this is something near and dear to my heart because I work a lot in the hypertrophic cardiomyopathy clinic, and some of the hemodynamics for this are very similar. This usually occurs in the setting of an apical infarct, and in order to make up for that apical akinesis, the basal myocardium becomes quite hyperdynamic, and that results in dynamic outflow tract obstruction. You have less blood moving out the outflow tract, so you get hypotension, and you can get a murmur and diagnosis with echocardiogram. But you might look at me and say, well, Geske, who cares? right? All these outcomes, this person's hypotensive. What's the big deal about this one? It's because management differs, right? When you have this person presenting with hypotension, you give them a beta blocker, right? A beta blocker is going to decrease that hyperdynamic basal myocardium and actually paradoxically improve your blood pressure. Furthermore, you want to avoid inotropes or a balloon pump because both of those things are going to worsen your dynamic outflow tract obstruction. So management differs despite similar presentation of hypotension post-MI. So recognizing this is important. We're now going to shift gears a little bit and go from the unruptured complications into the ruptures. Ruptures usually occur in the first week. Okay? This is when neutrophils are going into the myocardium. As they infiltrate into the myocardium becomes mushy, purulent, and that's when it's most likely to tear. If lytics have been given, it may occur slightly earlier. For the ruptures, it can encompass papillary muscle rupture, ventricular septal rupture, or free wall, and first we'll talk about that of papillary muscle rupture. We know the papillary muscles are prone to rupture because they are a subendocardial structure. Despite that, this is still pretty rare. It occurs in less than 1% of infarcts. It's in that magic window of when the neutrophils are going into the myocardium. And because of the decreased coronary flow, we get decreased blood flow to the papillary muscle ruptures, and it's preferentially affecting one of the papillary muscles. I find diagrams sometimes to be a little bit easier to explain concepts, and for this one, I think it works fairly well. The anterolateral papillary muscle has a dual blood supply coming from the LAD and the circumflex. So if you occlude one of those vessels, it's still well supplied. However, the posterior medial papillary muscle usually receives a single blood supply from the PDA, which arises from the right coronary, about 70% of humans. And when you occlude that vessel, you may all of a sudden develop papillary muscle rupture thereafter. These patients present with acute severe mitral regurgitation. Normally, the left atrium is a low pressure chamber, but you have a sudden rise in left atrial volume. The left atrium can't accommodate it, so it backs up into the pulmonary venous system and results in flash pulmonary edema. You have an increase in flow going backwards, so your forward flow goes down. You have a decrease in forward stroke volume, a decrease in cardiac output. Because you have a decrease in forward volume, your carotid barrel receptors are being stretched less. Via a reflex arc, they turn on the sympathetic system, which increases your systemic vascular resistance, which is good for a moment because it increases your end organ perfusion, but it makes things worse for the heart. Now you have an increased systemic vascular resistance, so you have more mitral regurgitation. More mitral regurgitation means less forward outflow. Less forward outflow, lower blood pressure. So the system keeps going and going. You get this vicious cycle of hemodynamic decline. These patients present sick. They're acutely dyspneic from their pulmonary edema. They're hypotensive. They may or may not have a new systolic murmur. Sometimes, if there's so much mitral regurgitation, you can have rapid equalization of the LV and LA pressures. It's almost like there's just one chamber, and so you may have a very quiet or even absent murmur in these patients. Here's an example on transesophageal echocardiogram. We see here the left atrium mitral valve, and you can see that there's a papillary muscle attached to that posterior mitral leaflet that's just flinging back into the left atrium with each systole. No surprise, when we put color Doppler on this, we have torrential mitral regurgitation. Would not be surprised if this patient did not have a murmur. Treatment is urgent surgery. As the surgeon is coming in, the OR is getting ready, you may need to stabilize these patients. They may need a balloon pump, pressors, but you're going to be sending them to the surgeon immediately. We know that this is a high-risk operation. The surgeon's operating on mush, right? It's hard to repair something that's so mushy, and so oftentimes this is a mitral valve replacement. Mortality can be high, but even with that high mortality, it's better than medical therapies. So once you identify this, the clock is ticking. Risk factors include advanced age, worse hemodynamics that needed a balloon pump, or poor LV to start. What about septal rupture? Septal rupture is another rare complication. It occurs in the same time frame. And here we see an example. This is a short axis, and we can see in this basal inferior septum, there's a break in myocardial continuity right there. If we put color on, we can see a left to right shunt. This occurs in elderly women, oftentimes their first infarct, they've not developed any collaterals. And it's a split between anterior MI or inferior MI. If it's an anterior MI, it's typically in the apex, and it's an LID that wraps around the apex and supplies blood to the entire apex. Now, if you have an inferior MI, this tends to be at the base, like the echo example that we just saw, and that inferior MI can be a little bit more serpiginous, a little bit more twisty-turvy, and can involve the annulus as well. These patients will have a harsh systolic murmur, oftentimes accompanied by a thrill, and although you're sending more blood through the pulmonary circuit, acute pulmonary congestion is rare, and this leads to the age-old adage that a new systolic murmur with the patient lying flat is a VSD, and a new murmur with the patient sitting bolt upright in pulmonary edema is mitral regurgitation. The hemodynamics of this, you have a left to right shunt, so you get a LV volume overload. You may have an oxygen step up on a right heart catheterization. And the shunt is bigger when there's a bigger hole, when it's harder to eject blood out the left ventricle, when it's easier to eject blood out the right ventricle, or when the LV is weak. And at first that LV weak didn't really make sense to me, but if you have a decreased forward stroke volume, then you activate that baroreceptor reflex, you increase your systemic vascular resistance, and that's what drives a bigger shunt. Hemodynamics, you do get an increase in pulmonary artery pressures from that pulmonary flow, and so you get a V wave. So a V wave is not a great way to distinguish between MR and VSD. Initial treatment, inotropes, afterload reduction, balloon pump, these are all a Band-Aid. What you want is you want to get your surgeon involved because even a stable rupture can abruptly expand. And if they have one of those basal serpiginous ruptures, that can be really challenging. Sometimes the surgeon will say this is one that's really technically difficult and you may end up observing. Mortality is high with these, but we still send them to surgery if we can. Some of these we can percutaneously repair if the borders and the anatomy is amenable. Free wall rupture is our last of the rupture complications. We'll first talk about frank free wall rupture. This typically presents with death. 8 to 26% of deaths post-MI. This is typically in that window when there's all those neutrophils coming in. This is an elderly woman presenting with first anterior myocardial infarction. An elderly woman presenting with first anterior myocardial infarction. And to drive that home, I'm going to show you a video of an elderly woman presenting with first myocardial infarction. Right? Many patients don't make it to the OR because they develop PEA arrest, rapid hemopericardium. We know that these patients are elderly women with first MI. There's not good collaterals. And if they've received steroids or lytics, delayed lytics, they may be more likely to proceed with this. Pericardial tamponade, PEA arrest. What I will say is that if you have an elderly woman with first anterior MI and they have an unheralded vasovagal event, right? That just makes the hair on the back of your neck go up. I would have a high suspicion for a partial rupture. You can get an echo, look for pericardial effusion. This may be your only clue before sudden cardiac death. Most cases of this in the literature are small because patients oftentimes die. Mortality rates are very high. What about contained rupture? What does that mean? So contained rupture is sometimes called a pseudoaneurysm. I don't like that term because it's not as descriptive. Contained rupture, I think, is a better term, but they are synonymous. This is about a third of all cases of free rupture, and this is where you've almost ruptured all the way through the free wall, but not quite. You have an organized thrombus or just a single layer of your visceral pericardium that's holding the blood in. This can often be clinically silent. You have just this thin layer. It's not all layers that are involved, and you can see here that it has a thin neck. Okay, so with a thin neck, doesn't involve all layers, just thin layer out here. It's a false aneurysm. These have potential to complete rupture. And so if you identified something like this very shortly following an infarct, here we see out at the apex, there's flow into this little sac right here, yikes, and seen also with contrast. If this was seen immediately following or in that kind of magic window of mushy myocardium, you want to get your surgeon involved. Every once in a while, we'll see one of these very late on, and if they're outside of this window of mushy myocardium, sometimes they can be observed. So when you identify a rupture, you're going to get on the phone with your surgeon and pleasantly tell them, there's a rupture, and the surgeon is going to say to you, oh, good, where's the rupture? And you have to say, oh, well, actually, the echo is on the way in. And so when you identify this, you want to call and confirm. It's good to know to call your surgeon, but don't forget you want to confirm the anatomy of this as well to help your surgeon do the right thing. Have a high suspicion, bring them in, but confirm as well. We're going to shift gears. We've done all the mechanical. Now we're going to go to some of the electrical complications. So I'm a pretty simple guy, and I know that tomorrow you are going to have a full day of electrical complications. So this is going to be briefer. And in my mind, things go fast or slow, and they could be from the top of the heart or the bottom of the heart. So that's kind of how we're going to organize this. And we're going to start with fast things that come from the bottom of the heart, ventricular arrhythmias. In the setting of acute MI, VT or VF is the most common thing that's going to be leading to out-of-hospital arrest. Here we see an example of a strip where we're going from sinus into VT. If you have a patient in VT or VF, get them out of it. You don't need a doctorate for that one, right? Okay? In addition, you're going to want to correct the things that you can correct. You're going to want to fix the electrolytes. If they're hypoxic, you want to fix that. You want to eradicate ongoing ischemia and treat pump dysfunction. What about PVCs? Should we try and suppress PVCs? Well, that's a question that was asked in the CAST trial. And you can remember it was the CAST trial, and that Dr. Amann thinks it's very important because he even signed the CAST. Okay? So the CAST trial looked at suppression of PVCs in the setting of acute MI with class 1 antiarrhythmics, things like flecainide. And what they found is while they could suppress the PVCs, that these patients actually had more ventricular arrhythmias. It was pro-arrhythmic. And because of that, there was more death. So don't pursue PVC suppression. Don't use class 1 antiarrhythmics in patients with coronary disease. Right? Even Nish thought that was important, okay? So remember the CAST trial, that's why we don't use class 1 antiarrhythmics. If you have patients who have VT or VF greater than 48 hours after their initial event and you've already treated the things that you can, you've eliminated the ischemia, then you need to think about an ICD. But do not confuse this with primary prevention ICD, which will be covered in depth tomorrow. And I'm not going to go into things like LifeVest and some of those things because, again, those are going to be covered tomorrow, and we don't want to have too much overlap in the electrical complications. For supraventricular arrhythmias, it's pretty easy. The most common one is going to be atrial fibrillation. And there can be a lot of different mechanisms that I've listed here on the slide for your review that result in AFib. And that's the reason why up to 1 in 5 patients in the setting of acute MI can develop AFib, even if they've not had it before. It's most common in the elderly and patients with heart failure, existing hypertension. So what do we need to know about these? Don't use the class 1 antiarrhythmics. We just said that, right? The CAST trial. And there's a challenge of triple therapy, and Nandan just gave us a nice outline of that challenge of TOAT, was it? T-O-A-T. So that comes along with its own set of complications. Bradyarrhythmias, this is when things go too slow. So sinus bradycardia can be quite common, especially in inferior MI, because there's a lot of vagal tone in that setting. Oftentimes this is self-limited and can just be observed. If the patient is symptomatic or hemodynamically unstable, your first thing that you reach for is atropine, and then you could think about temporary pacing if that's insufficient. AV block, interventricular conduction delay, the bigger the infarct, the more likely you are to have it, and also more likely with inferior infarcts, as we just said. If you get a new bundle branch block, you're affecting your conduction system, you're more likely to develop high-grade AV block. So then the question comes up, who do we pace? So the people to pace are those who present with asystole. Again, you don't need the doctorate for that one, okay? Symptomatic bradycardia or high-grade AV block, Mobitz 2 or third-degree AV block. But what I will say is this. If you have someone who comes in with an inferior infarct, you may be able to observe some of the high-grade AV block if the patient is hemodynamically stable, asymptomatic, because oftentimes those are transient. Whereas for an anterior infarct, you're going to have to be more aggressive. There are some other things that my EP colleagues tell me about. I've listed them here for your review. I think that they're good to have on paper, but I don't think they're going to be the high-yield things emphasized on boards. Who leaves the hospital with a permanent pacemaker? Persistent and symptomatic second and third degree AV block. That's pretty simple. There are some other things, again, here that my EP colleagues made me put in, but what I would say is, again, look for high degree AV block despite things that have been resolved, that's persisting, those are the people that are going to end up needing long-term pacing. I'm going to shift gears one more time into our last segment of the talk. This is the segment on non-myocardial disease. I actually think this looks a little bit like Dr. Bowen's aorta that was in the seatbelt. But that's not what we're talking about necessarily, the aortic complications. We're talking about non-myocardial complications, which encompass the pericardium and the thromboembolic and bleeding. So for pericardium, we had a great lecture by Dr. Amann that went through a lot of the pericardial pathophysiology. And what we know is that the incidence of acute pericarditis following STEMI has gone down in the setting of acute reperfusion. Asymptomatic pericardial effusions are common following a STEMI, but if you find one, you got to be thinking, could this be one of those rupture complications? Because you don't want to miss those. So any effusion, make sure that's come into your mind. Aspirin is how we treat these. This is not 81 milligrams or 300 milligrams. This is 600 milligrams every 4 hours. I think I've heard Nish teach before that you give it till their ears ring and then you cut back a little bit. So this is high-dose aspirin given to these patients to settle down the inflammation. You can use colchicine, acetaminophen, but what we don't use are steroids or NSAIDs, because those actually end up causing more problems with some of the mechanical complications as well as LV systolic function. When we look at some of the trials, there haven't been a lot of specific trials for post-infarct pericarditis, but if we kind of generalize some of the pericarditis trials, COPE and ICAP, what we've learned is that addition of colchicine to the regimen decreases recurrence of pericarditis as well as recurrent hospitalizations associated with pericarditis. So my regimen for these patients is to put them on high-dose aspirin and accompany that with colchicine. So the take-home point from COPE and ICAP is to consider colchicine for acute pericarditis, even in the setting of post-MI. Let's talk about thromboembolic and bleeding complications. Here we have an example of a left ventricular thrombus. So on this contrast echocardiogram, we see here that there's a defect found in the apex. This can many times go along with a true aneurysm. When you have an apical true aneurysm and you have akinesis of that area, you can end up forming a thrombus. You get stasis of flow. This is much more common in the setting of a reduced ejection fraction, and these do carry along with embolic risk. If this is identified, anticoagulation should be pursued, and this should be followed with serial imaging. You are in that bind, likely, of triple therapy, because most likely this patient has just had an acute MI, they're on dual antiplatelet therapy, and now they have a reason for an anticoagulant as well. Why don't we just give everyone warfarin out the door, just say, hey, triple therapy for all, because bleeding complications worsen all of the potential outcomes that we follow in the setting of STEMI. So it's independently associated with current MI, stroke, death, longer hospital stay. So we need to be judicious about who we select for long-term therapeutic anticoagulation. Wake up now for the last 2 slides, and we're just going to recap. When you have an MI, you can have a lot of different complications. In fact, we've discussed more than 14 complications during this talk alone. And so it's great to have a framework to organize them. For these complications, they can be mechanical, and within mechanical, you can have unruptured or ruptured complications. The unruptured complications include profound LV failure, RV infarct, LV true aneurysm, ischemic mitral regurgitation, and dynamic outflow tract obstruction. We've outlined the presentation of each of these. We've outlined the hemodynamics and pathophysiology of these, as well as management approaches. There's also ruptures, and ruptures, while uncommon, are oftentimes deadly. And these are a board's favorite. They were heavily emphasized on my boards. Even though we come across these so rarely because they're lethal events and timing matters so much, recognizing papillary muscle rupture, septal rupture, and free wall rupture, whether it be complete or frank or contained, is important. In addition, we have electrical complications. These could be tachyarrhythmias, which are either ventricular tachyarrhythmias or supraventricular, or bradyarrhythmias, encompassing that of complete heart block, asystole, need for pacemaker. We can also have non-myocardial complications. These involve either the pericardium or bleeding and thrombotic complications. So what pearls, what are the things you really want me to know, Geske? So here we go. Avoid high-dose IV beta blockers in large acute myocardial infarction. That's our first key trial that we discussed. In those patients that are younger, presenting with cardiogenic shock, pursue early PCI or CABG. And in fact, it's probably good to do for just about everyone because of the long-term outcomes. In RV infarct, you have a trio of reduced blood pressure, clear lungs, elevated JVP. These patients are going to have an S3 and a preserved Y descent. We're going to reperfuse and give them IV fluids. You give them IV fluids even though the neck veins are up because the left ventricular preload is reduced. Know the difference between true versus false aneurysms. One has a broad-based neck, one has a narrow-based neck. One affects all layers, one affects just a thin layer. One is a rupture complication, that being the narrow neck. One is not. One has low rupture risk but may develop neurothrombus. When you have an elderly woman presenting with first anterior myocardial infarction, particularly if she has a history of hypertension, you need to be aware of the potential for rupture. You need to have a high clinical suspicion because that alone may save them. Things move very quickly in these syndromes. If you have a patient who is lying supine and develops a thrill, think about VSD. This distinguishes the person, the position, if they're upright and they're in frank pulmonary edema, respiratory distress, you may or may not have a murmur. That's when you're going to think about acute MR, something like papillary muscle rupture. The position of the patient helps you decide what's going on, but then you're going to confirm it with imaging as you call your surgeon. And in the setting of VT post-MI, treat the ischemia, correct the electrolytes, and then observe. Additional VT beyond 48 hours is a reason to get your EP colleagues involved. Thank you so much for all your time.
Very, very nicely put together. Let's go back to the questions about this 86-year-old who became unstable lying supine, who became unstable lying supine, who became unstable lying supine. And what is the diagnosis? Free wall rupture, VSD, right ventricular infarction, papillary muscle rupture, complete heart block.
I'm feeling good about this one.
Are you feeling good?
I am.
You think you'll get the applause?
I think so.
We hope
Seems like
so.
a sharp audience.
I know, but we'll find out. All right, let's see what people say. Okay, so these VSDs, and so why is there a big V wave here?
Yeah, so when you have a VSD, you're shunting blood left to right. So you're increasing your flow through your pulmonary circuit. As you increase your flow through your pulmonary circuit, all that blood coming from the lungs enters into the left atrium, and that's what generates the V wave in a VSD, as opposed to the V wave being the regurgitant volume going backwards through the mitral valve in the setting of a papillary muscle rupture.
So there's a lot of pulmonary vein filling when the mitral valve is closed into an atrium which is not used to filling, so the V wave goes up, and don't be fooled by that. And then the other thing is, so papillary muscle rupture, you're going to get the surgeon to operate right away. Have you gotten any of our surgeons to operate on a VSD right away?
I've called them. But what I will say, especially for those infero-basal, it can be so tricky because the course of the VSD can be really serpiginous, can involve the annulus, and it can be very challenging. Those patients are much more challenging to deal with. I will say I've had some patients who have had the anterior VSD that have been more amenable to a percutaneous option.
Yeah.
And so that is an option. It depends on the margins and the location of the VSD. And so I think it's really great if you have a multidisciplinary team. Even still, even if I'm thinking that this is one that can be treated percutaneously, I still want my surgeon on board. I'm still going to call the surgeon, but then I might bring in the structural interventionalist as well.
But I think from the practical standpoint, you have a papillary muscle rupture, you force the surgeon to operate and operate now, no doubt about it. But if you have a VSD and they're reluctant and an 86-year-old woman to go ahead, you listen to the surgeon, and it might be good. I mean, this is part of medicine. You might need to talk to the patient and the family and say, listen, we think that your chances of coming through are actually quite low, and we'll see what happens with your natural history. And there are some people, a few people who might survive without anything and stuff. But like Jeff said, especially the inferiors, very, very high risk. The anteriors, maybe we can close them with a plug, which sometimes it's nice. Have your surgeon on board, but don't push the surgeon for an older woman with a VSD. I think with experience, we've learned about that. Okay, so let's go to question number 2. 72-year-old man presents with 2 hours of crushing chest pain, inferior STEMI, has an RCA revascularization, taken to the CCU, heart rate 120, blood pressure 80. His venous pressure is elevated with X and Y descents. A third heart sound is audible, lungs are clear, and the next step in management is IV fluids, IV furosemide, emergency echo with a needle, cardiac surgery consultation, or IV dobutamine. Okay, they got it. Anything more you want to say?
I think it's important to recognize that classic triad: hypotension, clear lungs, elevated JVP, because this is a time when the elevated JVP is part of that trio, tells you that this is an RV infarct, and you're going to deal with that JVP differently. You're actually going to give more fluids because the LV is underfilled. Whereas if the patient was having profound left heart failure and their lungs are congested and this is up, you're going to actually have diuresis as part of your treatment arsenal as opposed to giving more fluids.
And do you want to say a word about V4R, because they might get a question on V4R lead?
So when you're getting your 12-lead electrocardiogram, your V1, that lead is placed just to the right of your midline. But it's not a great sample of the right ventricle. You know, you have AVR, V1, there's some leads that look a little bit at the right side of the heart, but not great. And so if you really want to sample that RV, you need to ask the ECG technician to run right-sided leads. And what they can do is they can place additional leads on the right precordium, so V1, V2, V3, V4. And those leads are going to give you a better sampling of the electrical vectors coming from the right ventricle and are going to be the best way to really sample what's going on there and confirm your suspicions for RV infarct.
Yeah, it's something we don't ask for very much, but it actually is quite useful in looking at an acute infarct of just the right ventricle, which sometimes can happen. So the other thing is, remember, if you have a person that you suspect STEMI and you get these vague things in the lateral leads, go out to V7 and V8, because you might be able to pick up some ST segment elevations that would suddenly turn you from a non-STEMI to a STEMI if you see that in the lateral leads. So just the electrocardiogram itself, you'll have some talks on tomorrow on the 12-lead electrocardiogram, but those are some hints that you can use in some of these very, very sick patients. Okay, question number 3. 75-year-old man develops acute dyspnea 8 hours after revascularization. You're concerned about acute papillary muscle rupture. With regard to papillary muscle rupture, which is correct? Anterolateral papillary muscles most commonly involved. Early beta blockade improves mortality. A harsh pansystolic murmur is typically present. Medical stabilization for 48 hours has worse prognosis and urgent surgery. Cardiac MRI is the preferred diagnostic choice.
Close.
1%. Wait, no, it's 95. Can't do it. 95%. Okay.
He's strict.
I'm strict.
Yeah.
Okay, any other words about papillary muscle rupture?
I think it's great to have a high index of suspicion for any of the rupture syndromes. Don't be fooled if a murmur is not present. But for this patient, they're going to be sitting bolt upright. They're going to be in respiratory distress. It's typically not a subtle finding as they're flooding their lungs with each beat, regurgitating back into that unsuspecting LA that didn't have that severe MR just a moment ago.
So your surgeon's ready do you need to go to the cath lab for coronary angiogram?
So that is a great question. It's one that I know has come up in clinical scenarios that I've been a part of. What I would say is this, is that time matters. Remember that there was a stopwatch on that slide. This is very much a need to get the patient to the operating room right away to fix the problem. What I will say is that as you've done your additional imaging to confirm the diagnosis of the papillary muscle rupture, you've actually got some additional information that hopefully will aid you in knowing that there's not something scary hiding in the other corners. This is most likely to happen in a patient with single vessel disease. It's their first infarct. It's also that you'll see that this is a hyperdynamic ventricle. It's squeezing, it's having its own stress test right at the moment in the setting of a papillary muscle rupture. And so you can look and see, are the other walls contracting as well as they should? And I think that those things in concert, which you're obtaining already as part of your imaging, give you even more support as you go down to the operating room without going to the cath lab.
Yeah, absolutely. So papillary muscle rupture, usually one vessel disease. If your ventricle's going like this, get them right to surgery. No need to stop, go, or anything like that. Now, you can have severe mitral regurgitation from papillary muscle rupture, but you can also have severe mitral regurgitation from papillary muscle dysfunction. How do you treat those differently?
Well, we do know that the treatments are different. So a papillary muscle rupture is going to be a surgical emergency. That's recognizing that that's the mechanism of the mitral regurgitation. You're going to be getting your surgeon in. You're going to be whisking the patient off there. In ischemic mitral regurgitation, your problem is the ventricle. So if there's ongoing ischemia, you certainly want to eradicate that. So if the patient didn't have this and then developed it suddenly, I might go bring them back to angiogram, see if there's a problem with the stent that was just placed, find out why they've developed acute ischemia that's resulted in this. You're going to be optimizing your hemodynamics as well. You're going to reduce your preload. You're going to decrease your afterload. You're going to utilize medicines that help the ventricle remodel, that prevent remodeling of the ventricle, that are medicines that help to restore a more normal architecture to the subvalvular apparatus.
Yeah, so most of them you can actually get out of heart failure. And the only indication for ischemic MR to operate is if they have persistent, intractable heart failure following many days of aggressive medical therapy, because they're a pain to operate on. And if the surgeon is going to go in and operate on ischemic mitral regurgitation, despite the fact they think that they're really good with their hands and want to repair everything, don't let them repair. If the surgery is for heart failure due to ischemic mitral regurgitation, they need a valve replacement, because we found out over the past decade or so that these repairs just don't last, and the ventricle gets worse and they come back with more mitral regurgitation. Now, speaking of medical therapy, one of the questions that was asked is, you said that if they have cardiogenic shock, let's say from severe left ventricular dysfunction, try to avoid putting in a balloon pump until you've exhausted medical therapy. And they were asking, well, what medical therapy can you give if their blood pressure is only 90 or 95?
Yeah, so I think you're going to select which medicine you choose first based upon the hemodynamics. So having someone whose systolic blood pressure is 95 is a different story than someone whose blood pressure systolic is 70. So whether you choose something like a dobutamine or a dopamine versus going to something like norepinephrine is going to depend upon where your systolic pressures start. But what I would say is this: there's a tendency when these patients come in cardiogenic shock, they're very congested, they're complaining of shortness of breath, maybe they develop respiratory instability, they're hypotensive. There's a tendency to reach for a diuretic, as we might do for someone who comes in with a more stable congestive heart failure, to try and diurese them first. But in patients with cardiogenic shock, acute profound LV failure, you need to support the ventricular contractility first. You need to reach for your inotrope before you would ever reach for the diuretic to try and relieve the congestion.
Yeah, and this is one where some gentle afterload reduction with nitroprusside can be very, very effective in increasing forward flow. One last question about indication for surgery for a true aneurysm, a broad-necked aneurysm.
Yeah, so that's a good question. Many times these can be observed. I guess if you had a very profound, huge true aneurysm, and you thought that it was that by operating you could remodel the ventricle better and improve systolic function, that would be a possibility. But many times these patients are treated with typical heart failure cares. So this is going to be beta blockers, ACE inhibitors, anticoagulants if a mural thrombus has formed, as opposed to operative intervention on true aneurysms, because they don't rupture. They involve all layers of the myocardium. They have very low rupture risk. And so it's seldom that we operate on them.
Yeah, and it's probably only after weeks that they develop intractable heart failure or intractable ventricular arrhythmias that you would go in and operate. Otherwise, you're right, they remodel and they do very, very well.